Welcome to the deep dive. Today we're tackling, well, a really high-stakes subject. We're drawing from advanced surgical masterclass materials, the kind of deep training aimed at, real surgical mastery.
That's right.
Our focus is the pancreatic duodenectomy, the Whipple procedure. It's truly a pinnacle of abdominal surgery.
Absolutely. And we're trying to move beyond just the how-to. This is about transformative learning,
Yeah,
asking the why, asking for whom, and crucially, what's the expected outcome.
right.
This whole deep dive is structured around the kind of collaborative teaching simulations that demand, well, absolute precision, anatomical precision, really nuanced diagnosis, and sophisticated planning. Evidence-based strategy at every single step.
And our mission today is navigating what these source materials call the periampullary conundrum, which sounds intriguing.
It is.
Imagine you've got four totally distinct tumors, different biology, different metastatic potential, different prognosis, but they all need the exact same single, incredibly complex operation.
That's the heart of it. It's where surgical skill meets, well, biological reality.
It's the central paradox, isn't it? The surgeon needs to be technically brilliant, of course.
Absolutely essential. But the ultimate outcome, it's often dictated before the first incision by the tumor's cell of origin, its inherent biology, not just the skill of the hands. Understanding these different biologies, that's what defines mastery here.
One operation, four biologies. That really sums it up. Okay, let's start by defining that main term. Okay, let's unpack periampullary carcinoma. So it's a geographical term, basically, based on location.
Exactly. It's all about the neighborhood. These tumors grow right around that critical junction, the ampulla, where bile and pancreatic juice flow into the small intestine.
Got it.
And identifying the four specific primary sites, that's step one in figuring out what you're dealing with. First, there's the ampulla of Vater itself, the little valve or nipple structure, prognostically often the most favorable.
Okay, the ampulla itself. And then moving outwards.
Correct. Second, and unfortunately the most common and aggressive, is cancer, starting in the lining of the head of the pancreas. That's pancreatic ductal adenocarcinoma, PDAC, the one we hear most about.
All right.
Third, you can have tumors starting a bit higher up, in the lining of the distal common bile duct. That's a CBD cholangiocarcinoma.
Okay.
And finally, tumors can arise from the lining of the duodenum itself, the second part, right around where the ampulla sits.
So four distinct origins. But the key insight, as you said, is they can all look identical at first.
Identical clinically, yes.
Yeah.
That's the challenge. They're all perfectly positioned to block bile outflow. And that blockage, it leads to the classic, really ominous sign, painless, progressive jaundice.
The word painless always stands out. Why painless? If something's blocked, you'd expect pain, wouldn't you? Like with gallstones.
Good question. It's all about the speed. A gallstone usually causes a sudden acute blockage. The bile duct spasms, distends rapidly, bam, intense pain, biliary colic. But a malignant tumor, say from the pancreatic head or ampulla, it grows slowly. It causes a gradual narrowing, weeks, maybe months.
So the body kind of adapts,
That's right.
accommodates.
Exactly. The ducts dilate slowly, bile backs up gradually, but without that sudden stretching or spasm. So the patient might notice they're getting yellower, maybe some dull backache, but often no sharp acute pain. That slow progression is the clue.
Okay, so the bile flow gets blocked. What does that actually do to the patient? Let's detail those classic symptoms.
Well, the symptoms are a direct result of bile not reaching the gut. The liver conjugates the bilirubin fine, makes it water-soluble, but it can't get out. So it backs up into the blood, and the kidneys filter it out. Result: strikingly dark, almost tea-colored urine. That's conjugated bilirubin in the urine.
And the opposite effect in the bowel.
Precisely.
Yeah.
No bilirubin pigment gets into the intestine to give stool its color. So the stools become very pale, light-colored, often described as achlolic or clay-colored.
And then there are the systemic effects, which sound quite severe.
They can be profound. Significant, unexplained weight loss, cachexia, sometimes really rapid. And one of the most distressing symptoms is severe pruritus. Intense itching all over. That's from bile salts depositing in the skin, irritating nerve endings. It's miserable for the patient and a sign of significant toxicity. Often needs urgent relief, usually by drainage.
So painless jaundice, dark urine, light stools, maybe itching and weight loss. That picture leads us straight to a classic physical exam finding, Courvoisier's law.
Yes, Ludwig Courvoisier. A fascinating piece of clinical history from the 1890s, still relevant. The law states, if a patient is jaundiced and you can feel an enlarged, non-tender gallbladder. The cause is likely malignant obstruction, not gallstones.
Okay, but why wouldn't gallstones cause an enlarged gallbladder if they're blocking things?
Because chronic gallstone disease usually involves inflammation, cholecystitis, that leads to scarring, fibrosis in the gallbladder wall. It becomes thick, rigid, inelastic. It just can't stretch and enlarge like that.
Ah,
Malignancy, on the other hand, is typically a slow, smooth obstruction. Bile backs up gradually, letting a relatively healthy gallbladder distend smoothly, painlessly. It becomes palpable. It's a powerful distinction. Well, practically speaking, with modern imaging.
right. We're probably relying more on CT or ultrasound than actually feeling the gallbladder these days, especially in larger patients.
Exactly. But the principle, the mechanism, is still sound.
So imaging helps, but labs really quantify this cholestasis. What's the classic biochemical signature we're looking for?
You're looking for that mechanical post-hepatic obstruction pattern. So total and direct bilirubin will be way up. Confirms conjugation is happening, but egress is blocked.
Okay.
And crucially, the enzymes associated with the bile ducts, alkaline phosphatase, ALP, and gamma-glutamyl transferase, GGT, they'll be significantly elevated, sometimes massively high, hundreds, even thousands, reflects the back pressure.
And this differs from, say, primary liver failure, where a STOLT would be sky high.
Correct. Here, the liver cells themselves aren't the primary problem. They're just dealing with the backup. So you'll see a mild rise in AST and ALT, maybe 2-3 times normal, but they're completely dwarfed by the huge jump in ALP and GGT. That pattern screams cholestasis, blockage.
Okay, that makes sense. Now, this brings us to a really debated marker, CA 19-9. The case in the materials was interesting deep jaundice, but CA 19-9 was only 85. That seems low for pancreatic cancer, doesn't it?
This is such a critical point. It separates basic interpretation from advanced understanding. CA 19-9 is almost useless as a standalone number. You have to interpret it alongside the bilirubin level. Think about it. An aggressive, bulky PDA usually needs significant tumor volume to really crank out CA 19-9, often into the thousands, sometimes tens of thousands.
So if the bilirubin is really high, meaning complete obstruction, but the CA 19-9 is low or only mildly up,
That's actually paradoxically reassuring. It strongly argues against a big, nasty PDA, that picture. It's classic for an ampullary carcinoma. Because of its location, even a tiny tumor at the ampulla, just millimeters wide, can completely block bile flow. So you get early, profound jaundice before the tumor grows large enough to produce tons of CA 19-9. This early presentation is why ampullary cancers often have a better prognosis.
that's a really sophisticated interpretation, low CA 19-9 being good news in the face of bad jaundice. But there's another major catch with CA 19-9, right? It doesn't work for everyone.
Absolutely. The Lewis antigen non-seeder status, a
Yeah.
crucial nuance. About 5 to 10% of the Caucasian population, genetically, they just don't make the enzymes needed to produce the CA 19-9 antigen.
So they could have widespread disease.
A massive metastatic PDC, and their CA 19-9 level could be 0 or very low. It tells you nothing of those patients. You absolutely cannot rule out cancer based on a low CA 19-9 if you don't know their Lewis status. It's a major pitfall.
So definitely not a screening test, not great for initial diagnosis in everyone, but it still has a role.
Yes, its most reliable use is after diagnosis. For monitoring recurrence, tracking how the disease behaves over time, assessing response to therapy. We also watch it before surgery if the bilirubin comes down after stenting, but the CA 19-9 stays sky high, that's a bad sign, suggests a large tumor burden that isn't just related to the blockage.
Okay, clinical picture's suggestive, labs fit. Now we need definitive staging. Before imaging, let's quickly touch on risk factors, especially for PDA, the big one here. What puts someone at higher risk?
Well, age over 60 is baseline, but the single biggest modifiable risk factor, cigarette smoking, doubles the risk, roughly.
Right.
Then there are conditions causing chronic irritation.
Uh-huh.
Chronic pancreatitis, definitely. Also, new onset diabetes in an older person who isn't obese, that's a red flag. High saturated fat intake is implicated too.
And what about genetic predisposition? When should we be thinking about familial risk?
Identifying high-risk families is key. The BRCA2 mutation, linked to breast and ovarian cancer, significantly raises PDAT risk. We also look for syndromes like chronic familial pancreatitis, Peutz-Jeghers, HNPCC, Lynch syndrome, Gardner syndrome. For these individuals, surveillance, often starting much younger with EUS or MRCP, is really important.
Makes sense. Now, for the staging itself, the gold standard imaging, triple phase CT scan. Why isn't a regular CT good enough? What's special about triple phase?
It's all about the blood vessels. Surgical planning hinges entirely on the tumor's relationship with critical arteries and veins, specifically the superior mesenteric artery, SMA, and the portal venous system. These vessels light up with contrast at different times.
Okay.
The arterial phase is captured quickly after contrast injection. It gives the best view of the SMA and the celiac axis, letting us see if the tumor is just touching, abutting, or actually encasing these vital arteries. That's a critical distinction for resectability.
Determines if surgery is even possible, basically.
Exactly. Then, a bit later, we capture the portal venous phase. This optimally shows the main veins, the superior mesenteric vein, SMV, and the portal vein, PV, confluence. We need to know precisely how involved these veins are. Misjudge that, and you might attempt an unresectable surgery or miss an opportunity for venous reconstruction.
Before we get to the NCCN criteria based on that imaging, the sources mention another radiological sign seen on MRCP or ERCP, the dual duct sign. What's that?
Oh, yes, the dual duct sign. It's a very strong clue. On imaging, you see simultaneous dilation widening of both the common bile duct and the main pancreatic duct.
Both at the same time.
Yes. It strongly points to a single blockage point right where they meet, usually a tumor in the head of the pancreas or the ampulla, squeezing both ducts. It helps differentiate from, say, just a CVD stricture further up or chronic pancreatitis changes alone.
Got it. Okay, now let's dive into the core of surgical strategy. The NCCN resectability criteria. This isn't just description. It dictates treatment, right? Starting with resectable.
Absolutely. Resectable means potentially curative surgery is feasible. Strict criteria apply. First, no distant metastases, M0. Second, the vascular assessment. There must be a clear fat plane separating the tumor from the SMA and celiac axis. Those arteries must be completely untouched.
And the veins.
Venous involvement is acceptable only if it's minimal. What we call abutment, meaning the tumor touches the SMV or PV, but involves less than 180 degrees of the vessel's circumference. If all that holds true, the patient can usually go directly to Whipple surgery.
Okay, that's resectable. The next category, borderline resectable, seems like a major shift in approach. What defines borderline?
Borderline means it's technically really challenging, maybe pushing the limits, but cure might still be possible. Radiologically, this could mean short segment occlusion of the SMV or PV, meaning we think we can cut out that segment and rebuild the vein.
Okay.
It also includes short segment abutment of the hepatic artery, and crucially, short abutment less than 1 centimeter of the SMA itself. That SMA involvement is really pushing the boundary.
And the immediate critical consequence of being borderline.
This is the huge split in management. Borderline resectable tumors require neoadjuvant therapy first. Chemotherapy, often with radiation. You do not go straight to surgery.
Why not?
The goal is to shrink the tumor, pull it away from those critical vessels, sterilize the margins, especially near the SMA and TV. Essentially, you're trying to downstage the tumor biologically and anatomically to significantly increase the chances of getting a complete negative margin, R0 resection, when you eventually do operate.
And what kind of chemo are we talking about here? Something aggressive.
Usually, yes. For PDOC, the trend is strongly towards potent regimens like FOLFIRINOX, that's fluorouracil, leucovorin, irinotecan, and oxaliplatin, or maybe gemcitabine, combined with nab-paclitaxel, given before surgery. FOLFIRINOX is tough, it has significant toxicity, but it often gives the best shot at shrinking these borderline tumors enough to make surgery feasible and potentially curative.
Okay, then the final category, unresectable or locally advanced.
This means curative surgery just isn't possible anatomically. The tumor is too involved with vital structures. Key examples are encasement more than just touching of the celiac axis or the SMA. You simply can't get a clean margin without causing catastrophic damage. And of course, any distant metastasis, stage 4B disease, automatically makes it unresectable.
So the focus shifts completely.
Completely to palliation, managing symptoms, maybe biliary stenting or bypass for the jaundice, pain control, perhaps palliative chemotherapy to slow progression, but curative surgery is off the table.
So staging is done. Before we plan the definitive treatment, we usually need a tissue diagnosis. And this brings up the biopsy dilemma that the materials really stressed. Why is sticking a needle through the skin, a percutaneous biopsy, so dangerous for suspected PDAC?
It's about preserving the potential for cure. The major risk is tumor seeding. When that biopsy needle goes through the abdominal wall and into the tumor, then gets pulled back out.
Cells contract back along needle path.
Exactly. Viable tumor cells can get dragged along the needle tract and deposited onto the peritoneum, the lining of the abdominal cavity. If those cells implant and grow, that's peritoneal carcinomatosis. That's stage 4B metastatic disease. It instantly takes a potentially resectable, curable tumor and makes it incurable, a complete disaster.
Wow. So you absolutely have to avoid breaching that peritoneal cavity.
Absolutely critical. The preferred, much safer method is endoscopic ultrasound with fine needle aspiration, USFNA. The scope goes down into the stomach or duodenum, and ultrasound guides a needle fired through the gut wall directly into the pancreatic mass.
So it never enters the main abdominal cavity.
Correct. The needle path stays within the gastrointestinal tract lumen or wall. This dramatically minimizes the risk of peritoneal seeding. It's the standard of care when resectability is being considered.
Okay, so pathology confirmed, staging complete. Even if it's deemed resectable, the patient doesn't go straight to the OR, right? The sources emphasized preoperative optimization, often needing a 2 to 4 week delay. Why is that delay so important?
Because we're about to subject the patient to one of the biggest physiological stresses imaginable. If they go into a Whipple, malnourished, deeply jaundiced, catabolic, their risk of major complications and death skyrockets.
So what happens during that optimization period?
Several things. Allowing time for the jaundice to improve helps liver function, clotting factors. But arguably the most critical part is aggressive nutritional support, reversing the weight loss, the muscle wasting. This might mean high-calorie oral supplements or even total parenteral nutrition, TPN, if they can't eat enough.
Building them up for the fight ahead?
Precisely. A well-nourished patient with good albumin levels, good muscle mass, simply tolerates the surgery and potential complications, especially leaks, much better. This isn't delaying treatment. It's investing in their ability to survive the treatment. It's crucial.
All right, patient-optimized staging confirms resectability. We proceed to the Whipple. You said it's 5 hours on a good day. It involves removing a lot and then putting it all back together.
It really is the Mount Everest of abdominal surgery for many. The resection part involves taking out the distal stomach, or sometimes preserving the pylorus and taking just the duodenum, plus the entire duodenum, the head of the pancreas, the gallbladder, and the distal common bile duct. A huge specimen.
And then the reconstruction. The triple anastomosis, that sounds complex.
That's where the real technical challenge often lies. You have to reconnect to the plumbing. 3 major connections need to be made, usually to a loop of jejunum, the small bowel. The most critical, highest-risk one is the first, the pancreaticojejunostomy, connecting the cut edge of the remaining pancreas back to the intestine.
That's the one we worry about leaking.
That's the one. Then second, the hepaticojejunostomy, connecting the remaining bile duct from the liver to the jejunum, so bile can flow. And third, the gastrojejunostomy, or duodenojejunostomy, reconnecting the stomach or duodenal stump so food can pass through.
Okay, now let's circle back to something we touched on earlier, that big shift in thinking about pre-op biliary drainage, PBD. It still feels weird leaving someone really yellow for weeks before surgery.
It does feel counterintuitive. And for years, draining the vial with a stent before surgery was standard practice. But high-quality evidence, especially from large trials like the Dutch DRP study, has shown it often causes more harm than good in the routine setting.
So standard now is?
The current standard, strongly supported by evidence, is to avoid routine PBD, putting in a stent in patients who are stable, don't have infection, and are planned for upfront resection.
What did that DRP study actually show? Why is putting in a stent potentially harmful?
The core problem is infection. As soon as you place a stent, whether endoscopically or percutaneously, you create a highway for bacteria from the duodenum to climb up into the normally sterile biliary tree. That stent quickly gets colonized with bacteria, forms a biofilm. The DRP trial and others clearly show that patients who had pre-op stenting had significantly higher rates of serious postoperative infectious complications. We're talking wound infections, intra-abdominal abscesses, sepsis, particularly dangerous if the pancreatic anastomosis leaks into a field already contaminated by that stent.
So the potential benefit of lowering bilirubin slightly is outweighed by the increased infection risk after surgery.
Exactly. The data shows it doesn't improve overall survival or reduce major non-infectious complications, but it definitely increases the risk of post-op sepsis. The main exceptions are if the patient presents with acute cholangitis, a biliary infection they need draining urgently, or if there's a planned, necessary delay for neoadjuvant chemotherapy, then you usually do need to drain the jaundice first so they can tolerate the chemo.
Got it. Okay, surgery's done. Let's look at the pathology report from the simulation case. It came back as intestinal-type adenocarcinoma from the ampulla of Vater. Clean margins are 0, and only 1 out of 22 lymph nodes positive. This brings us right back to that 4 biologies idea.
Yes, this pathology report tells a completely different story than if it had been PDAC. Ampullary cancers, because of where they sit, tend to cause symptoms earlier when they're smaller. They often have lower rates of lymph node spread and, importantly, less tendency for perineural invasion compared to pancreatic cancer.
And how does that translate into prognosis? Can you quantify that difference?
It's a dramatic difference. For resected ampullary cancer, the 5-year survival rates are generally in the 40% to 60% range.
Yeah.
That's pretty good, more like some advanced colon or gastric cancers.
Okay. And PDA?
For resected PDA, even with clear margins and negative nodes, the 5-year survival struggles to get above 25%, maybe 30% in the best series. If nodes are positive, it's even lower. The underlying biology is just fundamentally different, much more aggressive systemically.
So for the ampullary case, what are the favorable markers you look for in the path report?
You want to see that intestinal type histology, it generally does better than the pancreatobiliary subtype. Obviously, R0 resection, negative margins is critical. Low lymph node burden is good. And the absence of things like perineural invasion or lymphovascular invasion are also favorable signs.
Let's clarify R0. It means no tumor at the edge. But specifically for Whipple, there's one margin that's notoriously tricky, right?
Yes. The retroperitoneal margin, sometimes called the SMA margin or unsenating margin, that's the tissue plane dissected right off the superior mesenteric artery. It's deep, hard to get wide clearance. Getting an R0 resection means achieving a microscopically negative margin everywhere. But that posterior margin is often the most challenging and the most critical for preventing local recurrence. An R1 resection, where there's microscopic tumor left behind, drastically worsens the prognosis.
Okay. So this ampullary case was N11 positive node. What did the tumor board recommend for adjuvant strategy? Does node-positive ampullary cancer need chemo?
Yes, for node-positive ampullary carcinoma, adjuvant chemotherapy is generally recommended. Because its biology can resemble colon cancer, we often extrapolate from those protocols. Regimens like capecitabine, oral 5-FU, or perhaps FLF-OCX might be used.
But it's not as mandatory as for PDA.
It's recommended, but the survival benefit is more modest compared to PDA. So the decision needs careful personalization, weigh the potential benefit against the patient's age, overall health, potential side effects. It's a discussion.
Whereas for node-positive PDA,
There's no discussion. Adjuvant chemotherapy is mandatory. Usually aggressive multi-agent chemo like fumvalanox or gemcitabine capecitabine. The risk of systemic recurrence in PDAC is so high, you have to hit it hard postoperatively. It just highlights again that deep biological difference dictated by the cell of origin.
Okay, let's shift to post-op. The Whipple has arguably the most feared complication in abdominal surgery. The post-operative pancreatic fistula, or POPF, that leak from the pancreatic connection.
It really is the Achilles heel of the operation. The pancreatic angiostomy is notoriously prone to leaking. And the reason lies in the pancreas itself. The tissue could be incredibly soft and fragile, especially if the pancreas wasn't diseased or fibrosed beforehand. Surgeons sometimes describe sewing it like trying to stitch wet tissue paper.
Wet tissue paper? Wow, so a healthy pancreas is actually harder to sew.
Paradoxically, yes. A firm fibrotic pancreas, maybe from chronic pancreatitis or from the tumor causing duct blockage upstream, holds sutures much better. It's denser, the soft, healthy gland. Sutures can tear right through it.
And if it leaks, the fluid itself is dangerous.
Extremely dangerous. Leaking pancreatic juice contains powerful digestive enzymes, trypsin, lipase, amylase. Once activated, they literally start digesting surrounding tissues. This autodigestion can erode into major blood vessels, causing catastrophic hemorrhage, or lead to widespread infection and sepsis if the leak isn't contained by drains. It's a cascade of potential disasters.
Which is why surgeons adapt their technique based on gland texture, like ductal mucosa versus invagination.
Exactly. There are different ways to make that connection. Ductal mucosa involves precisely sewing the pancreatic duct lining to the jejunal lining. It's meticulous, technically demanding, often preferred for softer glands if the duct is big enough. Invagination involves burying the cut end of the pancreas into the jejunal lumen. Simpler perhaps, but maybe less secure in soft glands. Choosing the right technique for that specific pancreas is a critical intraoperative judgment call.
So postoperatively, the team needs intense vigilance, especially around post-op day 5. What are the warning signs of a POPF?
Vigilance is key. You're looking for signs of inflammation. Maybe a new fever, say 38.5, 38.8 Celsius, an unexplained fast heart rate, rising white blood cell count. But the most specific sign is often a change in the surgical drain output. Suddenly, the volume might increase, or the fluid changes character from clear or serosanguinous to cloudy, murky, brownish, or even purulent.
And the definitive test isn't just looking at it, it's lab analysis.
Absolutely. You sent that drain fluid to the lab. The definitive diagnosis of POPF is based on the amylase level in the fluid. If the drain fluid amylase is more than 3 times the upper limit of normal serum amylase, you have a pancreatic leak. That often means levels way up in the thousands, sometimes over 5,000 UL. If you see that number, it's a leak, period.
And then you grade it using the ISGPF grading system, ABC, because
Mhm.
not all leaks are clinically equal.
Correct. The grade dictates management. Grade A is just a biochemical leak. High amylase in the drain, but the patient is clinically well. No fever, no pain, eating fine. You just watch them closely, maybe leave the drain a bit longer.
Okay. Grade B.
Grade B is a clinically relevant POPF. The leak is causing problems. The patient might have fever, pain, inability to eat. They require active treatment. NPO, nothing by mouth. TPN for nutrition, often antibiotics. Their hospital stay is significantly longer. Maybe they need an extra drain placed by interventional radiology if a collection forms. But usually grade B can be managed non-operatively.
And grade C is the worst case scenario.
Grade C is a life-threatening leak. Major clinical deterioration. Sepsis, organ failure, like kidney failure, major bleeding from eroded vessels, or diffuse peritonitis requiring urgent intervention. Grade C often necessitates a return to the operating room for washout, control of the source, extensive drainage, carries a very high mortality risk.
So if you suspect a grade B or C leak, what's the immediate management protocol? What are the first steps?
You have to act fast and follow the protocol. 4 key steps. 1. Keep the drain in. That existing surgical drain is potentially life-saving. It's controlling the leak, preventing it from spreading internally. Do not pull it prematurely. 2. NPO and TPN. Make the patient NPO immediately. Stop all oral intake. Start total parenteral nutrition to provide calories and rest the pancreas completely, reducing secretions. 3. Broad-spectrum 5E antibiotics. Start them right away. Leaked pancreatic fluid is a great place for bacteria to grow, leading to abscess or sepsis. Cover broadly. 4. Urgent CT scan. Get an urgent CT scan of the abdomen and pelvis with contrast. You need to see the extent of the leak, look for any fluid collections that aren't being drained adequately, and might need percutaneous drainage by IR.
What about drugs like octreotide or somatostatin analogs? Do they help shut down pancreatic secretions?
That's debated. They do reduce pancreatic secretion volume. However, large trials haven't really shown that prophylactic use, giving it routinely after surgery, prevents clinically relevant POPF. Once a grade B or C leak is established, many surgeons will use octreotide or similar drugs acutely as an adjunct. The thinking is it might help decrease the volume of caustic fluid leaking out, buying time for healing. But it's definitely not a magic bullet and never replaces the core management: NPO, TPN, drainage, and antibiotics.
Wow. Managing POPF sounds like a huge challenge, really defining post-op success or failure. Okay, let's pivot now. The sources also highlighted mastery in handling unexpected problems during routine surgery, moving from the Whipple complexity to a standard laparoscopic cholecystectomy, gallbladder removal, where the big risk is accidental injury.
Yes, even in common operations, unexpected anatomy or events demand critical thinking. In lap col, the absolute bedrock of safety, the non-negotiable step to prevent bile duct injury, BDI, is achieving the critical view of safety, CVS, before clipping or cutting anything presumed to be the cystic duct or artery.
Okay, the CVS. Can you detail the 3 specific criteria that must be met?
Absolutely. 3 distinct visual confirmations are required. 1. Clear the triangle. You must completely dissect all the fat and fibrous tissue out of Kello's triangle, the space between the cystic duct, the common hepatic duct, and the liver edge. No hidden structures allowed. 2. Expose the liver bed. The lower third of the gallbladder itself needs to be lifted up and dissected off the liver bed, exposing the flat plate of liver underneath, the cystic plate. This gives you perspective and ensures you're not mistaking the common duct for the gallbladder base. 3. 2 structures only. This is the final check. You must clearly see only 2, and exactly 2, tubular structures entering the base of the gallbladder neck. That should be the cystic duct and the cystic artery. If you see 3 structures or only 1, or if you're unsure you have not achieved CVS and you must stop and reassess, maybe convert to open surgery or get help.
And failing to achieve CVS is how most BDIs happen, misidentifying the common bile duct.
Precisely. Mistaking the common bile duct for the cystic duct and clipping or cutting it, that's a devastating injury, potentially requiring complex reconstruction like a hepatococcygeostomy and carrying long-term risks. CVS is designed specifically to prevent that misidentification.
Okay. Now, in the teaching scenario, the surgeon is getting the CVS, everything looks good, but then a small stone pops out of the gallbladder neck area, Hartman's pouch, and disappears. Just a tiny stone. Why does that seemingly minor event immediately trigger the need for an intraoperative cholangiogram IOC, even if the pre-op liver tests were normal?
Because that little stone is a huge red flag. It's a sentinel event. It tells you there's likely communication between the gallbladder and the common bile duct, and strongly suggests the possibility of choledochlythesis, other stones already sitting silently in the common bile duct.
Even if LFTs were normal?
Absolutely. Normal LFTs do not rule out CBD stones if they aren't causing a blockage at that moment. If you ignore that little stone, finish the gallbladder removal, you might be leaving stones behind in the main duct.
Setting the patient up for problems later.
Exactly. They could come back days or weeks later with jaundice, pancreatitis, or cholangitis, all because of the retained stone. Now they need a second procedure, usually an ERCP, which carries its own significant risks, particularly post-ERCP pancreatitis in 5–10% of cases. Seeing that stone during surgery is your chance to deal with it in one go. You have access via the cystic duct. You should use it to check.
Okay, so you decide to do the IOC. How is it actually performed laparoscopically?
You make a small cut, a ductotomy, in the cystic duct wall. Then you insert a fine catheter through that cut, directing it towards the common bile duct. You secure the catheter, maybe with a special clamp or a suture ligature, to prevent contrast leaking back. Then, under X-ray guidance, fluoroscopy using a C-arm, you slowly inject contrast dye.
And what are you looking for on the X-ray images, the 3 critical views?
You need a systematic evaluation. 1. View 1. Confirm the catheter is correctly positioned in the cystic duct and shows it joining the common bile duct, CBD. 2. View 2. Watch the contrast fill the entire CBD, both up towards the liver, intrahepatic ducts, and down towards the duodenum. You're looking carefully for any filling defects, dark spots within the white contrast, which usually represents stones. They look like smooth, rounded shadows. 3. View 3, absolutely critical. You must see free spill of contrast flowing readily into the duodenum. This confirms the entire pathway down to the sphincter body is open and unobstructed.
So let's say the IOC does show a stone, a filling defect, even if contrast flows past it into the duodenum. What happens then? What are the management options?
If a stone is confirmed, you have 2 main pathways, often depending on the surgeon's expertise and the hospital's resources.
Proceed immediately with laparoscopic common bile duct exploration, LCBDE. This is the single-stage approach. The surgeon makes an incision in the common bile duct itself, coldicotomy, inserts instruments, often a small flexible scope called a choledocoscope, finds the stone, and removes them, usually with a basket or balloon. Then the duct is closed, sometimes over a temporary drain, sometimes primarily. This requires advanced laparoscopic skills and equipment.
Okay, 1 surgery does it all. What's option 2?
Option 2. Complete the cholecystectomy, close, and refer for post-operative ERCP. The surgeon finishes removing the gallbladder safely, maybe places a drain, and then arranges for a gastroenterologist to perform an ERCP soon after surgery, often the next day, to endoscopically remove the stone from the bile duct via the duodenum.
Why choose option 2?
Usually because the surgeon isn't trained or equipped for LCBDE, or perhaps the patient is too unstable for prolonged surgery. It avoids the technical demands of LCBDE, but it does mean a second procedure for the patient, and it exposes them to that risk of post-ERCP pancreatitis, which can be serious.
Makes sense. Now, if the surgeon did perform LCBDE, is there a final check before closing the abdomen?
Absolutely non-negotiable. After any exploration or manipulation of the common bile duct, you must perform a completion cholangiogram. Inject contrast again.
Why? What does it need to show?
It's the final quality control. It must confirm 3 things. 1, complete clearance, no residual stones or debris left behind. 2, ductal integrity, no leaks of contrast from your closure site or any accidental injury. And 3, rapid free flow of contrast into the duodenum, confirming no obstruction remains. Only when all 3 are confirmed is it safe to finish the operation. You know, this deep dive, looking through the lens of Prophet Dr. Selvaraj's Masterclass thinking, it really highlights the dual demands of modern surgery. On one hand, the immense intellectual precision needed for cancer staging, understanding vascular anatomy on scans, interpreting CA 19-9 correctly, knowing the evidence against routine PBD.
Right, that high-level oncologic strategy.
Yep.
And then, coupled with that, the absolute necessity for technical mastery and sound judgment in the moment, in the OR. Whether it's ensuring the critical view of safety in a routine case, reacting decisively to an unexpected finding like that stone, or managing the catastrophic potential of a pancreatic fistula with disciplined, protocol-driven care.
Exactly. True mastery isn't just memorizing steps. It's the nuanced application of evidence, critical thinking under pressure, adapting to the unexpected. That's the definition of transformative learning in surgery.
The goal isn't just doing the operation, but understanding the why behind every decision, tailoring it to the individual patient's biology and anatomy for the best possible long-term outcome.
Precisely. It's about judgment informed by deep knowledge and experience.
So let's leave our listeners with a final thought to chew on, connecting this theme of precision and safety with future technology. We talked a lot about the risk of tumor seeding from biopsies and the critical need for CVS to prevent bile duct injury. Looking ahead, how might technologies like, say, intraoperative fluorescence guidance, using dyes that make bile ducts glow under special light, or maybe advanced robotic systems with enhanced tactile feedback and integrated imaging, how might these further minimize the already low risks? Could they help surgeons more reliably avoid ductal injuries, or even perhaps reduce seeding risk during complex resections in the next decade?
That's exactly where the field is heading. Integrating advanced imaging, AI-assisted visualization, and robotic dexterity directly into the surgical workflow to enhance safety and precision. That's likely where the next leap in surgical mastery will come from, improving outcomes in both complex cancer surgery and routine procedures alike. It's an exciting time.